हेलो चेक हेलो 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 सर एक हाँ आप मुझे दीजिए एक मिनट मैं ये निकालता हूँ फिर मैं कर दूँगा। एक मिनट ये खुली हुई है सर। हाँ होना चाहिए। सर मैं इसको जरा वो कर देता हूँ। हाँ एक मिनट रुको वो आंसर की ये अरे रुक तो लो यार ये डालू कहाँ रविकांत कर दिया टाइटल है एक मिनट खोल कर दिखा देता हूँ तुम्हें। पता नहीं they will talk about this thing. अच्छा एक मिनट अमित जी ये मैंने ये डाल दिया ठीक है ठीक है चल क्यों तुमने लिखा था अच्छा ठीक है चलने दो बस चलने दो वही है बिल्कुल ज़्यादा कुछ नहीं लगा अरे सब याद है बस ये इसमें मैंने डाल दिया बाहर में नाम से कर देता हूँ। अरे ये क्या आ गया अरे ये नहीं है भैया इसको तो
नहीं वो नहीं हमारा जो वो वाला फोन करवा
I think, can everybody settle down? Professor Gautam? Sir? I think we'll start the deliberations of the day. We are very proud and privileged to have today amongst us, despite his very busy schedule, Professor Ravikant, Surgeon par excellence, and also the Vice Chancellor of the King George's Medical University, one of the largest universities in northern India, largest medical university in fact. Thank you, sir, for coming and agreeing to talk here and also to chair this first session. We also have the other chairpersons, Dr. Muzaffar Ahmed. Dr. Muzaffar Ahmed is a man of disaster. He was the member of the National Disaster Management Authority, Government of India, till recently, and now represents the Medical Council of India. We also have the third chairperson as Dr. Kanjana Chuntai. We heard her yesterday. She's from Thailand, and she's the director of the Directorate of Nursing in Bangkok, Thailand. Over to you, sir. First talk. Yeah. The first talk of the day would be delivered by Professor Ravikant.
Actually, these trauma services are so relevant and pertinent today, and once we realize what is happening in our routine university system is that it simply doesn't exist as a very organized system. And I'll explain a bit here and there that if you see, this is our university, which is 105 years old, and we are running MBBS course right from 1911. The foundation stone was in 1905. And if we see, it's a fantastic area, over 156 acres of land. And many people have traveled far and wide across the world from there. And they are proving to be a very, I would say, role model in every place. And let's see what is happening in AIIMS. If you see, if you find the best 6 names in AIIMS as the teachers, almost all of them have one thing common, that they were from King George Medical School, Lucknow. Professor P.N. Tandon, and one after another I would take the name. So many Padma Bhushan, Padam Shri, all these people have come from there. It means it's a great center per se. And if we see the All India survey, it ranks today number 5 among government system. It is, we can say, number 3. So with that gamut in mind, huge facilities, so many residents, everything there, and we have got one It's a 3,000 bed facility. It will be 4,000 bed by December end. So a huge facility in terms of patient load. And where are we on this today? We get so many students every year in MBBS, BDS, post-graduation, various postgraduate courses, and we see what are the courses we are running, and you will suddenly see where are we with the trauma. So trauma is not here, although it is part of everyone, right from, it's a combined part of everyone, but not as a specialized course. When we see what courses we are running as a specialized course, I find so many other names in MCH and DM, but we find neither emergency medicine and nor trauma courses with us. Neither as a diploma. So there is a serious disaster mode when we see what are the department we are having. Again, I find per se the trauma emergency department now is at number 15. It means it's a late comer now. It is a big 6-story building now, and 4 stories are fully functional as on today. Another 2-story will be functional by, I would say, December end. So you can see the trauma emergency medicine even in a 100-year-old edition as a specialty is a very late entry. So that is the state of affairs which we are having. You can see there are so many other courses running for a very long time. Everything is there. But per se, the trauma services are not there, although we are quite capable of providing everything of them. And when we see what new department we have thought, and I left 2 places intentionally vacant here, the bottom one. And these bottom one vacancy is trauma surgery and emergency medicine. So it means despite an immense load of everything, despite a vision of being in the top ranking institution and proven to be so, the trauma and emergency medicine was continuously absent per se. We have got so many other medical schools affiliated to our parent organizations from far and wide in state. So in a way we represent the interest of the state as well. And why this data is important? This data is very important to know that population of the state of Uttar Pradesh is 22 crore, which is equivalent to whole population of Canada. It means you are directly responsible to something like Canadian medical system if you are managing Lucknow, per se in terms of philosophy and everything. Because from the capital flows the ideas to other district places and other medical schools. A lot of MOUs we have developed with the various national and international universities and collaborations. But end of the day, I find with so much research and in the research focus, the trauma and emergency medicine was not in focus at all. And now let me tell you what is happening there. Today we have got a trauma center which is working is 4-story high. It's a Y-shaped building, 3 wings in each slot. We have got roughly 300 plus bed facility. As on today we have 65 ventilator working at given time. By this month end it will be 104 ventilator working situation. So 42 ventilator will be added in this month or so. But my daily influx in my center is 300 patients average. So what to do? Question is what to do. What can we do to prevent or sort out this problem? The main issue is all peripheral areas, there is no facility to manage. So everything which is serious is immediately referred to the center, that is the Lucknow, which is the capital of state. And with 200 to 300 patients coming per day, if you see the 11 o'clock scenario, in the trauma center and emergency, it is a classical pathetic scene. 65 patients on stretcher being treated in the medicine department, 45 patients being treated on stretcher in surgery department, 35 patients on stretcher being treated in neurosurgery department, every pediatric bed having at least 4 patients per bed, despite running a drip and infusion pump and everything. It's a total, I would say, overdose of trauma and emergency medicine. So I have come here with this philosophy that now we have created a department of trauma separately, a department of emergency medicine separately. We are still in a process of, starting a course there, but this philosophy has been missed for quite long. I consider the national leaders, especially the AIIMS, combined 7. I think the main mission used to be that you have to be role model for others. So when the JPN model came, JPN Trauma Center came, it became like a big role model that you can develop on along lines, you can develop courses, give a better treatment. But question is, what about a state which is overpopulated? What about a place which is having 22 crore in a state and with you can't say no to any single patient? What to do there? And that is a big issue. My model is very simple. My model is when every district hospital becomes the medical school quality of service or a medical school itself, only then the Indian problem will be solved. Till that time, this problem will remain as it is, which is a total, I would say, overdose at certain centers and other centers not knowing what to do. And there are 4 or 5 reasons for that. Why these centers want to refer quickly. The rationale is very simple. The rationale is very simple. The rationale is that if there's someone dies in a peripheral center, apart from everything else, there is a law and order situation. There is a big fight between the public and the treating doctors. There is a chance of getting physically harmed by the doctors. And in order to prevent that, they feel it's better that we send someone straight away and not do anything else. It means now the time has come that we start trauma courses in every place, the trauma department in every district, or trauma in emergency, or we can say A&E in the UK term. But I can tell you, a good surgeon who will manage trauma will not be able to manage a heart attack. This will be too much to expect from him. Although the UK model says so, that A&E model can succeed. My feeling is A&E model in India is unlikely to succeed. The surgeon will be more like an American model that manage the trauma depending on level 1, level 2, level 3 and so on. And the emergency model again will be depending on how much ICU support is there, how much coronary support you have got, how much cardiac cath lab support is there. Because we have 3 cardiac cath labs which can run 24 hours. So I can manage any patient who comes, whatever is to be done can be done in the same campus within a short time, and probably that is the reason we are, sometimes you pay for being too good. And I feel this paying, it is also a model that yes, poor patients will get treatment free. That is another good thing which I feel special about Lucknow, that all poor patients get treatment free. They don't have to pay anything either on arrival or departure or during. But those who can afford, they will be charged a minimal token amount of whatever charges are there. But there is a huge quota by the government and by the courtesy of government that all poor patients will get free treatment there. So this philosophy is entirely different to American model, where everyone has to pay something other. So it means we have now come to that level where we have to find, number one, what is the economy model? Should we put on the charge model? Should we put on the free model? Should we put on a Robin Hood model, rob the rich and give to the poor? I think the Robin Hood model will be better for India, number one. That's the economy. Number two, How to manage the overload? The overload is only when we popularize this trauma and emergency service everywhere, in every medical schools. How many medical schools run trauma and surgery or I would say emergency medicine course? Answer is barely minimal, barely minimal. Less than 1% is my data evaluation today, how many run this thing. Therefore, this major shift is required to run in every district, to run in every medical school and manage the quota. I didn't show too many crowded scenes where from the medicine ward, the stretcher goes up to the outside, the ward, they go up to the lift and everyone is there, but everyone being managed in some way there. Sometimes it is a suboptimal care, I agree, because your resident, your faculty numbers are limited. The patients are unlimited. Question is, what are the solutions? And I leave it to the audience to decide how should we manage more, how should we move from this point, which is a very big challenge in terms of political management, economic management, medical management, equipment management, and manpower management. Thank you very much.
Thank you very much, Professor Ravikant. And our next speaker is Maria Wildwood, who is an emergency and nursing nurse with over 30 years of experience in emergency setting. I would request her. Her comments we'll do at the end of the session.
So we can all the presentations. Also is better than yeah, that's right.
Which one?
Then we will happy to listen to your points. If she starts
I'm Deputy Director Administration at the All India Institute. See, thank you for the presentation. Thank you for coming for the workshop. We heard with great interest what you have said. What is the roadmap? Here is a great medical hospital that has had a legacy of almost 100 years, and it's not a very good trauma care institution. There's a long way for the King George's Medical Hospital to become, say, a JPNTAC like AIIMS. So, is there any roadmap forward, or what is the current thinking within your administrative setup on how to take it forward?
I told you that roadmap is very simple. We have got a 6-story trauma center, right, which is taking care of these patients at this time. We have got another 300 crore project which is in SDPGI lying unused for almost 3-4 years for want of manpower and funds. And probably the government would start it soon. Essential thing is we don't have trained trauma surgeons, we don't have trained emergency medicine persons. Even if you advertise for faculty today, you will not find enough people to fill the job. So even the training center who are training, that number is not enough. If I want a trauma surgery professor, I won't get it easy. If I get professor of emergency medicine, I will not get it easy. So even if you have fund, the manpower is not trained enough. So we have to have matched both the things. While the funds build the building, at the same time the manpower should be trained by those who are already running it.
Supplementary also. What I understand is that we have huge crowds coming to a bad trauma center and we cannot improve it, in spite of putting monies in.
No, I think that is not an issue. Probably you are entirely misplaced in an air-conditioned environment. You have to come out of the air-conditioned environment, see in the evening what happens in a major trauma center. When a patient comes with multi-trauma, there are 3 types of accidents which happen. And I quote Professor P.N. Tandon on that. The first accident is a bad law which created a bad road design, and therefore this accident has happened. The missing helmet, the missing seat belt, the missing rear seat belt, all these things are the first cause of the accident. Second accident happens when you transfer from there to there. There is nothing like air ambulance, air rescue or anything. People are coming from Pilibhit, from Bahraich, from the, see the distance from they are traveling. There is a second accident, which again is a state responsibility. The third accident is the design of the hospital. When we see the reception, we don't create a classical crash area where the CT should be there, MR should be there, OT should be there, patient should be there. We have not even one suite designed in entire country which can manage crash area as per today's norm. The today norm is in 3 minutes pan CT should be done. It cannot be done in any center today. So it is the basically fault of the administrator that they have not looked beyond their air conditioned rooms. I regularly invite Mr. Gangwar, who was earlier here, and when he sees that, he says, what we are doing is just short of miracle. A beautiful environment, 65 ventilator working, 65 is a huge number of ventilators to run. It's not a small number. Ask any government organization how many ventilators you run. And now we'll be increasing to 100 pretty soon. So there is a lot of support from everyone, but this support will never be enough till the training area, that is the Bahraich, Basti, Balia, Banda, Bulandshahr, all these people are pretty strong. It's the training area which is weak, which is making us added to that.
I think very well said, sir. We need to strengthen our infrastructure down below on the secondary and the primary levels. Only then the load on the
We are
tertiary care
working on the
lines
apex, but downright is non-existent.
we're not. And second thing which came out from your talk was that you need to build up capacity both in terms of nursing as well as the trained doctors, surgeons who are managing trauma.
Trained technicians not available, trained nurses, trauma nurses not available, trained emergency medicine nurses not available, trained emergency medicine faculty not available, trained trauma surgery faculty not available. Beyond major medical centers.
So I would just sort of want to comment on the presentation from KGMU was that KGMU already is a level 1 trauma center that way. I mean, if you classify that. What we have learned from Gujarat model is that obviously these specialities, because they are de novo, new specialities, so let there be dedicated people, even general surgeons, who are dedicated for the cause of trauma, and then they come into this field and then train other people as specialists in trauma or specialists in emergency medicine. So you need to have a cadre which is already there, and medicine, internal medicine, anesthesia for emergency medicine, and general surgery for trauma surgery are already present. We just need to find out those dedicated people who would stick to trauma and train the generations into trauma.
Actually, Dr. Amit, I was focusing on the Canadian curriculum for emergency medicine.
Right.
That we put as a standard, right? We have to put the American model of the trauma surgery curriculum.
Absolutely.
That is the standard.
Right.
Rest everything is fill in the blank.
Yeah. So that's what we've done here, sir. Emergency medicine has already come up, and MCH trauma surgery would be admitted first batch in January.
Excellent. It's already there. It's already there. 6-story building only for trauma and emergency is already there for last 8 years. It's not today's job. No, it's already separate, it's administrative. Everything is separate. But we will be acquiring now the CPGI Trauma Center because they have shown their inability to run. So now KGMU will run it. Yeah. There also, in addition to.
And also we need to work for having cadre of EMTs, which is not existing as on date.
Exactly.
Good trained EMTs in the country.
Thank you. Good morning, everybody. My name is Moira Woiwad, and I'm an emergency nurse at the Alfred Hospital in Melbourne. And I'm here today to talk to represent the Alfred Hospital, but also the National Trauma Research Institute and the Victorian State Trauma System. So just a little bit of background about myself. You can see I'm a very sweet-faced 21-year-old girl there, finishing my nursing graduation. I did a 3-year vocational nursing course back in the late 70s, early 80s. And since then, nursing in Australia has certainly changed a lot. So nursing is now exclusively undertaken in universities, no more vocational training. But since then, I've had the opportunity to go back to university and study, to do postgraduate work, And it's given me the chance to work in a very sophisticated environment in the Alfred Trauma Centre, where I can work with advanced equipment to help manage critically injured patients. So in my talk today, I'd like to cover some aspects about the Alfred and the Victorian State Trauma System, what a normal nursing pathway in Australia looks like, and specifically looking at trauma nursing, education and capacity building. So Victoria, we had a look at this yesterday, a very small state in southern Australia, a population approaching 6 million, with 3.5 million licensed vehicles on the road. So if we look at Australia and we have the look at India in contrast, we can see that we live in a very large land space where India would virtually fit into Australia more than twice. And the population of Australia, last census, it was approaching 25 million compared to India at 1.3 billion. Number of licensed vehicles in Australia, around 18 million, and India rapidly approaching, this is for registered vehicles, 142 million. So we can see from that that comparatively there's a huge increased congestion, therefore increased risk of injury, accident and death. So I'm from the Alfred Hospital. The Alfred is the largest trauma service in Australia. And I'm also here to represent the work that's being done at the National Trauma Research Institute. It's a quaternary health service that has a strong commitment to research and teaching, and it's also the cornerstone of the Victorian State Trauma System. Annually at the Alfred, we would have around 15,000 trauma admissions annually, and about half of those would require admission to a hospital, and of them, about a third would fit into the severely injured category. The National Trauma Research Institute is a department of the Alfred Health, and it works in collaboration with Monash University. It was established in 2003, and since that time it's raised in excess of $60 million. And that money has gone into looking at improving trauma and healthcare systems to improve the care of injured people locally, nationally and globally. Importantly, the NTRI is also home to the Australian-India Trauma System Collaboration, and that was resulted from a grant from both the Indian and the Australian governments, and it's looking at bringing together governments, industry, clinicians and researchers to look at research, implement and pilot new ways of managing trauma systems of care. It's affiliated and co-located with Monash University, and importantly it's home to the Victorian State Trauma Registry, which is important for the collection of trauma and outcomes data, and it's that data that's used by government to improve quality in trauma. I think we saw this map yesterday, just a brief overview of the NTRI and Alfred Trauma Services, and looking at education and the impact that it's had through China, the Middle East, Southeast Asia and importantly in India. I've personally been privileged to have the opportunity to work in a couple of these places. I did work at Ludhiana at CMC University Hospital, where medical and nursing staff from the Alfred went and we conducted an education course, once again for medical and nursing, always in collaboration, and we were looking at all aspects of trauma care. Now that was done with private and public sector employees, and it also had some international participants as well. I've worked in China, in Longgang province, where we helped to set up the development of a new trauma centre, and we were involved with staff education prior to the international student games which were being hosted there. And most recently I had the opportunity to work in the Philippines in Manila General Hospital, and once again this was an integrated approach, medical and nursing, working together to intensely look at how we manage the first 10 minutes of the reception and resuscitation of the critically injured patient. It's just a brief overview of the NTRI and the Alfred Health activity through India. And we can see with the red pins that's indicating where the Australian-India trauma system collaboration is working. And the green pins are looking at the past and current activities, including consultancy, advocacy and education. So in the mid-1990s, there was growing concern about the number of trauma patients who were dying due to medical errors. And it was in 1997 that the Victorian government commissioned a multidisciplinary panel review of the care of all road fatalities over several years. And this review, which was known as the Rhodes Report, focused primarily on preventable deaths. And rather alarmingly, it found that between 30 to 40% of all road traffic accident deaths were preventable or potentially preventable. And the problems that it identified were in the management of all types of injuries and at all stages of the patient's care, so both hospital and pre-hospital. And it was really this report that paved the way for the foundation of the Victorian state trauma system. So the goals of the Victorian state trauma system were to reduce preventable death and permanent disability, and to improve patient outcomes by matching the needs of the injured patient to an appropriate level of treatment in a safe and timely manner. And to this end, that led to the development of 3 dedicated trauma centres throughout Melbourne. So the Alfred Health, where I work, a second facility at the Royal Melbourne Hospital, and a dedicated paediatric facility at Royal Children's Hospital. And all of these centres were staffed and managed by highly specialised medical, nursing, surgical and allied health staff to help maximise the patient's journey. In addition to that, it also saw the invention of the retrieval services for both adult and paediatrics. So this involved medical specialists flying or travelling to a place where a patient needed stabilisation before they could be transferred to a definitive centre. The 10 years following the implementation of this system approach saw that halved the in-hospital risk-adjusted death of major trauma patients. So we can see that the results show a significant impact on the mortality and morbidity statistics. In fact, the state trauma system has been so successful that it has been adapted and adopted by other areas around the world. Professor Keith Willett here endorsing the Victorian state trauma system, where he took some elements of that system and laid it down for the development of the trauma system in England. So this photo is a typical scene in the reception and the resuscitation of the critically injured patient. Some people here would be quite familiar with that, but others might think it looks quite crowded, but everybody there has a clearly defined role and expectation. We work as an integrated team to deliver a sophisticated response. We can see at the head of the bed there's an anaesthetist managing the patient's airway, and for those who know Professor Fitzgerald, he's in the middle there busy collecting information about the patient, making critical decisions regarding their interventions. The team is coordinated and it works in partnership to deliver timely quality care. So what is capacity building and how does it apply to trauma nursing? Well, the World Health Organization defines capacity building as the development and strengthening of human and institutional resources. So to apply that to trauma nursing, we're really saying that it's the education and the enabling of nurses to deal with managing the trauma-related patient. Capacity building helps to identify and understand what obstacles that restrict organisations from reaching their potential, as well as enhancing the abilities that allow them to achieve measurable and, importantly, sustainable results. So building trauma nursing capacity, there's a lot of aims and objectives there, but to summarise that, it's really to strengthen nurses, hospitals and governments in their ability to adopt measures to sustain the trauma and emergency nursing workforce. So it does involve quality measures, improving the quality and relevance of the nursing workforce, building local and regional partnerships, and that's really to provide technical and capacity building support for trauma nurses. Looking at education programs, are they relevant? Are they actually hitting what you need to be hitting? And is there consistency in the programs, and are they scalable on a national perspective? And very importantly, I think, developing strategies for the retention of staff and appropriate funding for those staff. If we don't fund trained, skilled nurses properly, we will always run into the problem of losing staff to other jobs, other countries, or other institutions. So hopefully the outcome of building capacity into this workforce will be a comprehensible and sustainable national strategy for trauma nursing. And we know that that results in more lives saved and reducing the burden of injury. So why are trauma nurses so important, and why do we need to invest in building capacity in trauma nursing? Well, we know that for a fact that trauma nurses save lives. They're essential and critical for the rapid identification of life-threatening injuries, comprehensive patient assessment, and enhanced intervention for better patient outcomes. But we also know that nurses are the harbingers of change. Where doctors may rotate in and out of a given department or hospital or region or even country, we know that nurses are a constant in the workforce. So they have the institutional knowledge or corporate history that goes with running that department. They understand processes, they know where to find equipment, how to get equipment fixed, how to make things move slowly. So it's important to empower them. I just want to look briefly at the trauma nurses' role at the Alfred Hospital. So obviously they're an integral part of the team at the Alfred, and providing clinical and clinical expertise and leadership throughout the patient's journey. So from the reception and resuscitation of the injured patient through to the dedicated intensive care unit and then to the dedicated trauma wards where nurses are skilled in optimising their patient outcomes. Nurses are vital also in the research aspects of maintaining trauma registries. They conduct audits and quality improvements. Many of the projects, the clinical and drug trials, are managed by trauma nurses. They're instrumental in researching evidence-based practice, which then guides trauma management. Also, education. Trauma nurses are involved in the development of short course development and implementation, as well as postgraduate training. Just a slide here to show the continuum in Australia from novice to expert. So graduate nurses' entry point being a 3 to 4 year bachelor degree undertaken, as I said earlier, at university. And then nurses can go on to develop in their specialty by undertaking foundation courses, which may be in-house, then going on to postgraduate studies, university, and going through the pathway through masters to a doctorate of nursing. So I'll just expand on those. Accredited foundation courses, and this would be an example of what we would be conducting. So the introduction to emergency nursing, which is also an introduction to trauma nursing, and it offers advanced physiology and critical clinical concepts, and really it lays the foundation for further learning. Another good example of a foundation course, which focuses primarily on trauma, is the trauma nursing program, and the core content of this really looks at the focus focuses on the management and system errors that were identified in the ropes course. So it consists of 2 clinical modules, emergency nursing and trauma management. The next step that a nurse would undertake in terms of her educational development would be the graduate diploma in emergency nurses. And really this is the cornerstone of our advanced education courses. In this course it's designed to teach nurses advanced pathophysiology and concepts of disease, and it gives them the qualifications to work with the critically ill or the critically injured patient. The course is designed to anticipate and prioritise patient care, and it enables the nurses to provide accurate assessment, intervention and effective ongoing management. This can be used as a pathway to a master's degree, and just to note that at the moment Monash University is in the process of developing a trauma-specific graduate diploma for nurses. In terms of advanced nursing practice, nurses can undertake masters leading to a pathway to a doctorate, and masters would be offered in clinical nursing, education or research. Other related short courses, and all of these courses are very easy to adapt or adopt to other countries. They can be easily transposed. Things that we would have as mandatory requirements would be the basic life support competencies, which is for anyone working in a clinical area in the hospital, and advanced life support for anybody working in a critical care area. Other options would be trauma resuscitation, and there's some courses there on statistics and research. I just wanted to briefly mention the professionalising of trauma nursing. In Australia we have the College of Emergency Nurses, and all professions, medical's probably much better at this than nursing, but all professions have peak associations that represent their alumni and set quality and benchmarking standards. And in Australia, the College of Emergency Nursing is the professional body that fosters excellence in emergency nursing, in education, practice and in specialised skills. And I think just from that professional aspect that they can benchmark quality standards but also education, and it's able to create a consistency, a national consistency within education. The model that I'm presenting here is a proposed pathway to trauma nursing capacity building. So how do we implement these measures to increase capacity? Well, first of all, you need to determine that you've got a problem and you need to work out really on what scale you want to attack that. So is it local, is it regional or is it national? And that is really dependent on funding, the impetus behind people, and having local champions that are going to really push for that. So the first stage of that is really developing a commitment. So a policy commitment from policy makers, from hospitals, from government. And hand in hand, we would need to look at the ABC of trauma care, the other ABC of trauma care, as Professor Fitzgerald calls it, the absolute budgetary certainty. So there's little value embarking down this pathway if you haven't got the funds, A, to start it, but B, to sustain it. So you need to make that commitment first. The next step would be the identification of the training goals. So recognising within your facility or your region what are the areas that require improvement or development. So it might be a local review or it could be a mini ropes report. Once training goals are identified, we really need to look at the development or identification of courses. So that could be a local thing, or you could involve someone like the Alfred or someone else that has past history on able to adapt and adopting courses and transpose them into other areas. And that's certainly something that we've done in the past, but making the education fit the need. We need to look at training and education, so identifying who needs to be trained and local heroes within that cohort who will then go on to be the trainers for the future to sustain the ongoing education. Mentoring and support, so really looking at mentoring and support from the key partners, and they need to continually evaluate the process. So that includes the auditing of the skills and the learning, formal evaluation, making sure that it's still appropriate. The development of a trauma nursing facility. So as I mentioned before, creating an alumni to exchange information, collegial support and professionalisation of the member body, but also helping to set national standards and to provide accredited training. And very importantly, maintenance and retention of the workforce. And once again, that goes hand in hand with the other ABC of trauma care. So it's important to financially compensate highly trained nurses, to reward their advanced training and their responsibility, and to stop them leaving the system to other places, other countries. Now, central to this pathway is a key partner, so someone who has accredited foundation courses, who can adapt them to local needs, and to always be maintaining an ongoing evaluation of the system and correcting where required. So what will building capacity in trauma nurses achieve? Well, empowering nurses through education has been demonstrated to improve outcomes for patients. They're essential to any fully functional trauma system, and they're suitably trained to assess and treat the complexities of the severely injured patient. As I said earlier, nurses are the harbingers of change, so empowering them through education will give them the knowledge. The increased capacity will be reflected in their ability to manage the complex trauma patient. We know that combining medical and nursing education into teams where they can work together in an integrated workforce improves the output, improves the timely quality of care for patients, and results in a reduction in the loss of lives and the burden of injury. So trained trauma nurses, better outcomes for patients. Thank you.
Thank you very much. Any questions? Is the salary different for trauma nurses versus ward nurses?
No, so it's more advanced. In the trauma, it would be under the management, the umbrella of emergency nursing, with a subspecialty in trauma nursing at the moment, but with plans to change that in the future. But it would definitely be advanced training, looking at critically injured people or critically ill people, complex needs, advanced ventilation skills, management of inotropic support, that kind of thing. So very much hand in hand with an intensive care nurses training. Yes, so it isn't specific to where you work, it's specific to what education level you have achieved. So if you have a graduate diploma and are working in a clinical area, you would receive a higher wage than somebody who didn't. And if you had a master's and were working in a clinical area, then you would be remunerated appropriately there.
So, it's not a question, but I just want to congratulate Moira for her presentation and also highlighting that nurses as they progress in their education and advancement in their clinical competence and leadership abilities, they need to be compensated. So while we are looking at the national system for trauma care in the country, we also need to simultaneously think of the career progression and the cadre for the nurses in this area. We can have certainly all the 3 or 4 levels of education that we have, but also to suitably help them to progress in their career within the trauma system. Otherwise, when we have the postgraduate programs, they prefer to go into education and become faculty and teachers rather than going back to do the clinical work. So I think this is a right time for us to look at that career progression and cadre for the trauma nurses. Thank you.
How much duration nurse normal who is graduate do this diploma in trauma nursing?
Sorry, I didn't catch all of that.
Yeah. Diploma.
The time.
Because we don't have, we have to plan it in India.
Okay, so a nurse would typically graduate from an undergraduate program, work in a specific area. So working in an emergency centre, and during that first 1 or 2 years, they would undertake foundation courses, and once they completed those foundation courses, they would be deemed ready to embark on the postgraduate course. So they're gaining work experience as well as learning, and then they would be good to go. And that's a 1-year course, the graduate diploma, and after that they would be, if they have passed the course, they would be deemed qualified to look after the critically ill and the critically injured.
So normally 3 years, about 2 years of
Yes.
experience in that area, and
Yes,
after
so
that
roughly
1 year
2
diploma.
years. And of course there's always differences, but yeah, we would normally say you would need some groundwork to really understand basic nursing, and then you can do advanced practice.
This diploma is a classwork, basically say class oriented, or it's a more of a practical?
So it is both. So it is an undertaking of classroom studies, a lot of it online studies, but it's being supervised, highly supervised at the different stages as you progress through that education timeline. So being supported and being making sure that that person has been able to fulfill that criteria for that particular module of learning.
Thank you.
So basically it's like in-house sort of in-service training program?
No,
So
it's not, but it is supported like that. So it is a university-based program, but because it is in a workplace, it does have that in-house component, yes. And emergency nurses would be the people that supported the emergency students. So they would be specifically educated in emergency nurses, in nursing and education.
Ma'am, I teach physiology here to the nursing students too. What I wanted to bring in was, apart from the protocols and processes for trauma, the professionality, I feel that trauma care is a very high stress environment, both for the victims, the entourage or the families, as well as for the caregivers. So there should be some component of local socio-cultural context-based handling also as a back-end support, and believe me, it does affect the healing outcomes. So the nurses, especially who are in trauma care, should have some kind of value-based or being more humane than the normal OPD and the normal ward care, because that really affects outcomes, I believe.
Well, it's very difficult to work out where and how you pay
Ma'am, just
different
like you
levels.
said that the social and the regional and the partnerships, I think from there the supports can come, the integration not just with the doctor,
Okay,
but
thank
with
you.
social
We'll go-
sciences also.
Excuse me,
Thank you.
we'll go to the next talk now.
Yeah. Thank you, Mary.
Thank you.
The next speaker is Dr. Bhaiti Batra, the National Board of Education in New Delhi. Dr. Bhaiti. Next speaker.
Thank you, Chairpersons, for inviting me to the session. Good morning, eminent delegates, ladies and gentlemen. During the next 20 minutes, I'll be sharing our perspective on specialized trauma courses, need of the hour. And the highlight which you can see in the hour is deliberate, intentional, and clearly makes an emphasis on linking the need for building up trauma courses, the capacity building for human resources required to manage trauma in the golden hour. A quick introduction of what we do. We are an autonomous institution established by the Government of India with a clear mandate in postgraduate trainings and assessments in modern medicine. The model of training and assessment which has been created at NB has been replicated by states and other verticals as allied health sciences by the Government of India. Over the previous days' deliberations, we have already seen the impact trauma has in terms of disease and mortality burden globally as well as in this country. It is very evident that this impact of morbidity and disease burden has clear linkages to the economy, spending, as well as has the potential to derail the entire planning of the health budget, especially in a low and middle income country like India, wherein the overall expenditure on health is low compared to Western standards, and a large fraction of the expenditure is out of pocket. So the data arising from some of the government agencies, National Crime Records Bureau, validates the figures which we have seen over yesterday, close to 3.5 lakh people dying due to trauma. The cycle of care, emergency care, a large fraction of that leading to hospitalization, a large fraction of that ending in morbidity, and possibly before morbidity, those who are lucky enough to survive entering into the cycle of rehabilitation and requiring post-curative care or continuity of care. So do we have the desired human resources which are required to manage this? All of us know that the management of trauma evolves around that golden hour, and that is why that emphasis on the hour promulgated by Dr. Donald Turkey, the right patient to right place and the right time. And we need critical human resources arising from allied health professionals, nursing, and competent surgeons and competent emergency physicians to deal with the 3 R's. Robust pre-hospital care, AHP, the role of AHP, nursing and medical doctors. In the ER room, the AHP, nursing and medical specialist, and followed by, depending upon the level of trauma center, the kind of specialists which we need. And I'll put a little emphasis here on one size fits all approach which we have been adopting so far, and the type of trauma surgeon and the competencies which we need to create in the trauma surgeon. And lastly, the much laid emphasis on the occupational therapist and PMR specialist. Do our present day curriculums and the training systems in all of the countries or ecosystems which we represent provide for regulatory framework that we can create these kind of human resources required? And secondly, if the regulatory systems permit to create these kind of human resources, the next question is, are they being competent and encouraged and motivated to pursue emergency management and trauma care as a career of their choice? Just an example of what could be the key competencies and action areas which our end product, the AHP and the nursing staff needs to practice in their respective domains. Friends, the level of trauma centers beginning from the apex to level 5 are known to all of us, and I'll just move through the levels of trauma center with emphasis on again the kind of human resources that we require. The clear emphasis here in level 1 is a multitude of specialists, emergency medicine, orthopedic surgery, neurosurgery, internal medicine, and all of them especially trained to work as a collaborative team. Level 2, the number of human resources required are less, but their competencies essentially remain the same and possibly more because we are working with less number of specialists, and given a situation, the competencies may have to overlap. And so on, if we move from level 3 to level 4 and level 5, the type of professionals which are required, essentially we are converging to a point wherein we are left with a general surgeon taking care of a myriad of issues, maybe the basics of neurosurgery, or maybe the opening up of abdomen, managing shock, and then discharging functions which have essentially come over a period of time in silos to be practiced by emergency medicine physicians. So as we talk of development of trauma care systems and the critical human resources required for health, the provision for creating competent emergency physicians as well as trauma care surgeons have to be defined with specific competencies marked from pre-hospital to definitive trauma care, raising that important question of key competencies required in our existing curricula, whether the existing curricula of undergraduate, postgraduate, nursing and AHPs provide for such proviso, and whether the present day regulatory framework are enabling in nature to ensure that continuous scholarship and motivation as well as the institutions which are providing the trauma care services are enabled to train and produce this kind of human resources which are required. An indication of a wide myriad of allied health professionals which are involved in trauma care settings. Roughly 17 different types of allied health professionals as are mapped in the report of National Initiative for Allied Health Sciences are there. Another burgeoning area about trauma surgeons and EM physicians. It's only out of the practice of trauma surgery that the discipline of emergency medicine has been carved out with areas of critical areas of functioning being delineated between the two. And now moving on to where our present day education system stands and addressing those two important questions about the enabling regulatory framework. In this educational pyramid, we have the derived from the World Federation of Medical Education 3-tier structure. We have the basic medical education, followed by the specialist education, and followed by the pathway of continuous professional development. A similar structure is followed in the field of nursing education, whereas in the field of allied health professionals, which I'll touch later on, the pathway is about to be carved out. So far, the training pertaining to trauma is focused in the apex part, with one course in fellowship National Board in Trauma Care existing for last 13 years, and a new course in MCH traumatology likely to be introduced by the Apex Trauma Center, part of All India this AIIMS initiative. There are other short-term training courses and CME courses available. In the nursing space, similar situation exists, wherein besides the basic nursing qualification, the other pathways are to the hands of the institutions which are providing trauma care services, with very little enabling or hand-holding support being provided by the professional councils at this stage. Emergency medicine, dealing with the golden hour, most importantly dealing with the pre-hospital care and the ER room management, has found its firm footing in India in the last 7 years, although it has been increasingly gaining prevalence in low and middle income countries, and the postgraduate specialty program in EM being recognized in over 60 low and middle income countries. In India, we currently stand at around 120 seats, with 48 seats of MD emergency medicine in 24 institutions and 66 seats in DNB emergency medicine at 21 institutions across India. All of these programs gaining momentum only in the past 3 years, with even the first batches of these programs yet to pass out. But the professional associations are working, the Medical Council, National Board and professional societies are working aggressively to take this to very acceptable levels, and target is to create 400 professionals in emergency medicine per annum in 5 years from now. FNB Trauma Care, a 2 years competency based program with entry requirements of general surgery, orthopedics and neurosurgery, running for the last 13 years. As on date, 24 candidates have been awarded the FNB qualifications. A mapping of the allied health professionals, most critical element considering the large reach as well as the number of service providers which we require at the pre-hospital care. The National Initiative for Allied Health Sciences was undertaken by the Government of India way back in year 2009, and the Government of India not just committed protected funds. Government of India took the initiative of setting up a National Institute for Allied Health Sciences, followed by 5 state institutes of allied health sciences. The major transformation, the word paramedic gave way to allied health professional. The mapping of national landscape was undertaken in line with the National Skills and Qualification Framework. The identification of courses has been undertaken on the HR needs assessment. The accreditation processes, standards and institutional framework, a sound foundation for the same has been laid down, and all this has now culminated. Just 2 weeks ago, the government has translated this vision into action by formulating a bill for the National Board for Allied Health Sciences, a body which will be like any other professional council or a professional board that will oversee the overall regulated and structured development of allied health professionals in the country. This bill is in the public domain, and we look forward that the bill gets cleared in the days to come. Friends, this is right from the NIAHS report, which was released in year 2014, the indicative list of various qualifications which are currently being offered in India at in each of the disciplines. And item 27 here, sorry for the small font size, pre-hospital trauma technology has been recognized as one of the key allied health professional programs. Besides, there are various other programs which are of direct or indirect relevance to the field of traumatology, like anesthesia technology, blood bank technology, central sterile supply technology, and so on. The available seat capacities at the centers of excellence for various specialities as they exist today, they have also been mapped out, and the emergency trauma and critical care technology in the current day settings stands at around 110 seats across the country. And this is the estimates on the shortfall of adult health professionals required at the national level, and in the field of surgery and anesthesia, which are of key relevance to the field of traumatology, the gap estimated is a whopping 8.6 lakhs. This is the heat map showing the AHP worker shortage across the country in various states, and the states with the darker red representation show the maximum shortfall. So practically the whole of country is reeling under a stage of crisis in terms of the allied health professionals. And this is the enhancement which is proposed in the courses so identified. And once again, the trauma and emergency medical technicians gain a dominant position here. BLS, ATLS and ACLS training, the embedded part. One issue which has been raised earlier is, are our current day training programs in that education pyramid sufficient to take care of competent medical graduates, nursing graduates and AHPs who can take care of the golden hour or the most easily required skills and competencies. These courses formulate the essential core, and in the last 8 years, thanks to the environment of promotive environment for traumatology education and initiatives of the JPN Center, ATLS today as well as the ACLS training is being undertaken at a much more larger scale than ever before, and a dialogue is currently ongoing between the Medical Council of India and the National Board of Examinations to make ATLS and ACLS training as an essential part, an integral part of the postgraduate training programs, as well as to a large extent in the undergraduate training programs. Coming to the nursing professionals, the role of nursing professionals is akin to none when it comes to pre-hospital care, ER, triage, critical care, operation theatre, post-trauma surgery, and even rehabilitation. But unfortunately, we do not have specialized courses or even an enabling pathway from the professional councils when it comes to nursing professionals. Even the environment which is promotive of scholarly activity or promoting excellence or specialized incentives is also missing in our current day workplace ecosystems. Some initiatives have been undertaken as part of the National Skills Development Mission, wherein a myriad of certificate courses have been launched in trauma nursing, and this is just the beginning, and hopefully based on the successful models, these programs are likely to be replicated across the country, across the institutions. leading to greater capacity building. But unless and until the ecosystem drastically change in promoting scholarly activity and incentivizing these initiatives, we are unlikely to attract any talent that could come over and proactively adopt traumatology as their career option of choice. Friends, yesterday we had the key statistics coming from the Government of India about the master plan of how the trauma center and the trauma care is being expanded across the country. The bed strength of the Apex JPN Trauma Center, currently 190, will go up to 260 and finally to 750. 27 level 1, 127 level 2 and 260 level 3 trauma centers. Thereby in total 600 trauma centers are at various stages of coming up. 12 new AIIMS-like institutions, 6 already in place, another 6 in the pipeline are already in the way. Various state government initiatives, 29 state governments are collaboratively working to strengthen trauma. That has been the big achievement in this country in the last 10 years, that traumatology from dialogue to action has evolved. And in private sector, 400 plus large-scale hospitals are already providing clinical services in field of trauma care to the public at large. What could be the master landscape when it comes to the human resources for health required to cater to